Okay, so students, in the part 2 of hepatitis infections video, we'll be covering hepatitis C, D, E, uh, G, and also the yellow fever. So, hepatitis C virus is the common cause of post transfusion hepatitis in developing countries. It was discovered in 1989 and first labeled as non A, non B hepatitis virus while performing the experiments in chimpanzees. Morphology: hepatitis C virus is classified under family Flaviviridae, genus Hepacivirus. It is spherical, 60 nanometer size and envelope. Nucleic acid: it contains a positive sense ssRNA. Proteins: HCV possesses three structural proteins: the nucleocapsid core, protein C, two envelope glycoproteins E1 and E2, six non-structural NS proteins: NS2, 3, S4A, NS4B, NS5A, and NS5B. One P7 member protein. Its function as an iron channel was earlier considered as NS1. Genetic diversity of HCV. Similar to HIV, hepatitis C virus displays diversity in the RNA genome that occurs because of high rates of mutations seen in the virus, which in turn is due to the high replicative activity, and second, the lack of proofreading activity of the RNA polymerase. Genotypes. HCV is divided into six major genotypes, subtypes. Genotypes are further divided into more than 100 subtypes. With any given patient, the subtypes of HCV circulate as complex, closely related viral population known as quasi-species. The E2 envelope protein is the most variable region of the entire HCV genome, followed by the non-structural proteins, especially NS5B encoded RNA polymerase. Hence, they are more prone to undergo mutations. Unfortunately, E2 protein happens to be the target site against which most of the neutralizing protective antibodies are produced. Thus, diversity in the gene encoding E2 protein enables the emergent mutant virus strains to escape from host humoral immunity, which in turn can result in establishment of chronic infection, failure to develop, failure of development of effective vaccine. The genotypes also vary from each other in their epidemiological distribution. Genotype 1 and 2 represent the most common variants in the Western countries. In India, genotypes 1 and 3 are more prevalent. Susceptibility to antiviral agents. For example, patients with genotype 1b respond poorly to therapy than other genotypes. Duration of the treatment needed. Transmission. Various modes of transmission of HCV are as follows. Parenteral. HCV is most commonly transmitted through exposure to infectious blood. Recipients of contaminated blood transfusions, blood products or organ transplants, contaminated needles, and sharp pricks. Injection drug users. Vertical transmission from infected mother to fetus may occur at much lower rate, 6%, than that of HBV, 20%. Sexual transmission is rare. Hepatitis C virus does not spread through breast milk, food, or casual contacts, including hugging or kissing. Clinical manifestations. Incubation period is about 15 to 160 days, average 50 days. Following an infection with HCV, asymptomatic infection. Acute hepatitis. About 20% of the people develop acute hepatitis characterized by symptoms similar to that of other hepatitis viruses described earlier. Rest patients remain asymptomatic in early stages. So, spontaneous clearance. In about 5 to 15% of infections, the virus gets cleared spontaneously within 12 weeks. Chronic disease. About 75% to 85% directly develop chronic disease, out of which 60 to 70% develop chronic hepatitis, 5 to 20% develop cirrhosis, 1 to 5% develop hepatocellular carcinoma. HCV accounts for 25% of total liver cancer. Extrahepatic manifestations. Due to deposition of circulating immune complexes composed of HCV antigens and their antibodies, in extrahepatic sites, various manifestations can be seen, such as mixed cryoglobulinemia, glomerulonephritis, arthritis, and joint pain. Epidemiology. Hepatitis C virus infection occurs worldwide. Every year, 3 to 4 million people are infected with HCV, with more than 3.5 lakh deaths. Population prevalence rate. About 3% of the world population has been identified with HCV worldwide, with more than 170 million chronic carriers. Higher prevalence rates have been documented from Africa, up to 10%, followed by South America and Asia. In India, the prevalence of HCV is about 1%. Lab diagnosis. HCV antibody detection assay, ELISA. The antibody detection tests have been the standard test for screening and primary testing for HCV diagnosis. ELISA is the most common platform used, followed by rapid test and chemiluminescence formats. First and second generation ELISA were used previously, now obsolete as they are less sensitive. Third generation ELISA, this has been the standard method for HCV serology. It employs antigens from NS5 antigen in addition to core NS3 and NS4 regions. Advantages include increased sensitivity and specificity more than 99%, not influenced by HCV genotype. It becomes positive in 5 weeks of infection. Disadvantages: these assays detect IgG antibodies to HCV, hence, they do not discriminate between active or past infections for which HCV RNA test is required, cannot differentiate acute and chronic HCV infection as IgG appears early and stays long, for which IgG avidity test is performed. Recombinant immunoblot antibody assay REBA. REBA was used in the past as supplementary test to confirm the ELISA result, which currently works on the principle of Western blot, not in use currently. HCV core antigen assay. Automated quantitative test detecting core antigen has been available recently. This test is less expensive and less time consuming than HCV RNA PCR. Advantages: antigen detection assays can be used as an alternative to HCV RNA testing for diagnosis of active or current infection, monitoring response to treatment. Disadvantage: they are less sensitive than RT-PCR, hence not recommended for blood screening purpose. An ELISA format has recently been available that detects simultaneously antigen, capsid antigen, and antibody to NS3 and NS4 antigen. Molecular methods. Real-time RT-PCR detecting HCV RNA has been the gold standard method for confirmation of active HCV infection. HCV RNA can be detected in blood as early as 2 to 3 weeks after infection. Quantification of HCV RNA for monitoring the response of treatment. For determining HCV genotype and subtype, it can also be determined by performing sequence-based method. Hepatitis C testing sequence. CDC recommends a two-step testing. First, anti-HCV antibody test is performed. If positive, then test for HCV RNA to identify active infection. If negative, then no further action is required except for immunocompromised patients where HCV RNA should be tested. Hepatitis C screening. CDC recommends one-time hepatitis C screening for all aged more than 18 years and all pregnant women. During each pregnancy, in areas with HCV prevalence, HCV RNA positivity is more than 0.1%. For high risk group, regardless of HCV prevalence, people with HIV, IV drug users, etc. Biopsy for staging HCV infection. It is a gold standard test for staging HCV infection that is helpful to determine the ideal timing of HCV treatment in some settings. Where biopsy is not obtained, fibroscan elastography is used to assess liver fibrosis. Treatment. Hepatitis C. The goal of treatment in HCV infection is to prevent development of complications such as cirrhosis and liver cancer, to achieve sustainable viral responses SVR, which is defined as undetectable HCV RNA in blood less than 15 international units per ml at the end of treatment. Interferon alpha plus ribavirin, earlier pegylated interferon PEG-IFN, alpha plus ribavirin RBV were used for treatment of HCV infection. This was associated with high adverse effects with a moderate degree of viral clearance. Direct acting antiviral agents DAAs. After the discovery of direct acting antiviral agents DAAs, the treatment of HCV infection has been revolutionized. DAAs are now the treatment of choice for HCV infection as they can reduce SVR rate up to 90% with minimal side effects. Three classes of DAAs are available: NS3-4A proteases inhibitors, NS5B polymerases inhibitors, and NS5A inhibitors. Combination therapy. Currently, the treatment regime for HCV includes combinations of different DAAs with or without PEG-IFN and ribavirin. Genotype specific. The drugs to be included in the regime depend on the genotype detected. Most DAAs are genotype specific except Bufir and Velpastavir, which are active against all genotypes. Duration. The duration of treatment regime is either 12 or 24 weeks depending upon the HCV genotype and presence or absence of liver cirrhosis. Predictors of treatment response. Genotypes. HCV genotype 1 and 4 are associated with poor prognosis than other genotypes. Subtype 1b shows poor prognosis as compared to 1a. Stages of disease. Presence of cirrhosis and associated co-infections such as HIV, HBV associated with poor prognosis. Adherence. Poor compliance to treatment is associated with worse prognosis. Viral RNA load. Higher the viral load, more than 8 lakh international units per ml, worse is the prognosis. Interleukin 28b is a strong inducer of interferon alpha. People possessing the subtype of IL-28B called CC genotype produce a stronger immune response to HCV infection by inducing interferon alpha release, hence have a better outcome. Race. Caucasians and African Americans lack CC genotype, hence show a poor treatment response than that of Asians. Others. Metabolic disorders such as insulin resistance, obesity, metabolic syndrome, steatosis, lack of vitamin D, supplement, older age, alcohol consumption all reduce the chance of responding to HCV therapy. In this table, we see the drugs used for hepatitis C virus infection. The directly acting antiviral agents DAAs, NS3 or 4A protease inhibitors, end with suffix previr, grazoprevir, paritaprevir, cimaprevir. NS5B polymerases inhibitors, ends with suffix buvir, dazabuvir, sofosbuvir. NS5A inhibitors, ends with suffix asvir, dactylazvir, ledipasvir, velpatasvir. Other classes interferons, pegylated interferon alpha 2A and 2B, nucleoside inhibitor ribavirin. Prevention. There is no effective vaccine available for HCV. General prophylactic measures are essentially same as that for HBV. Hepatitis D. Hepatitis D virus HDV is a defective virus, cannot replicate by itself, depends on hepatitis B virus for its survival. Morphology. Hepatitis D virus is taxonomically unclassified though resembles viroids. It is small in size 35 nanometer, consisting of circular negative sense ssRNA. Protein coat is made up of single protein called hepatitis D antigen, HDA antigen, surrounded by an envelope protein derived from HBs antigen from hepatitis B virus, hence it is called defective virus. Transmission. Transmission is similar to that of HBV and HCV. Parenteral route is the most common mode, followed by sexual and vertical routes. HDV and HBV association. The association of HDV with HBV is of two types. Co-infection, it occurs when a person is exposed simultaneously to serum containing both HDV and HBV. Hepatitis B virus infection sets in first so that HBs antigen becomes available for HDV. This is usually a transient and self-limited condition, clinically indistinguishable from acute hepatitis B infection. It rarely progresses to chronic stage 1 to 10% at a rate similar to that of HBV infection alone. Vaccination against hepatitis B can prevent against HDV. Superinfection. It occurs when a chronic carrier of HBV is exposed to serum containing HDV. After 30 to 50 days, this results in disease which may have two phases. Acute phase. This is the first stage in which HDV replicates actively with high transaminase levels with suppression of HBV. Chronic phase. All 100% patients progress to chronic stage in which HDV replication decreases, HBV replication increases, transaminase levels fluctuate, and the disease progresses to cirrhosis and hepatocellular carcinoma (HCC). Mortality rate is much higher, more than 20%. The order of frequency of chronicity of viral hepatitis in decreasing order is HDV superinfection 100%, more than perinatal HBV 90%, more than HCV 85%, more than HBV and HBV HDV co-infection 1 to 10%. However, in terms of absolute number of chronic cases or carriers, HBV accounts for maximum. Lab diagnosis. In co-infection, IgM against both HDA antigen and HBC antigen are elevated, although IgM anti-HDV appears late and is frequently short-lived. In superinfection, as HBV infection is already established as carrier, IgG anti-HBC will be detected. Anti-HDV would be IgM type initially, but as the patient progresses to chronic state, mixture of IgM and IgG would persist for months or longer. Anti-HBC antibody is the key to differentiate between co-infection and superinfection. IgM anti-HBC plus IgM anti-HDV indicates co-infection. IgG anti-HBC plus mixture of IgM and IgG anti-HDV indicates superinfection. HDV RNA is detectable in the blood and liver just before and in the early days of acute phase of both co-infection and superinfection. HBe antigen, the marker of active HBV replication, may be present in superinfection. Differences between hepatitis D and hepatitis B virus, HDV, HBV, co-infection and superinfection. Co-infection, HBV and HDV infection occurs simultaneously, while in superinfection, HDV infection occurs to a carrier of HBV. The patient's status in co-infection is healthy, while in superinfection is HBV carrier. The risk of development of fulminant disease is more than that of HBV alone in co-infection, and in superinfection it is even more than that of co-infection. Chronic hepatitis rare in co-infection while much greater in superinfection. Cirrhosis is rare in co-infection but more in superinfection. HCC is rare in co-infection but more in superinfection. Mortality is rare in co-infection but more than 20% in superinfection. Diagnosis: in co-infection we use HBs antigen, anti-HBC IgM antibody, anti-HDV IgM antibody and HDV RNA. While in superinfection we use HBs antigen, HBe antigen, anti-HBC IgG antibody, anti-HDV, in acute phase IgM, and in chronic phase IgG and IgM antibody and HDV RNA. Now coming to epidemiology, about 15 million people globally, that is 5% of HBV infected persons, are infected with HDV. Hepatitis D virus infection occurs worldwide, but prevalence varies greatly. Surprisingly, HDV is not prevalent in Southeast Asia, including India, where HBV carriers are maximum. Two epidemiologic patterns have been identified. In endemic cases, it is transmitted predominantly by non-percutaneous means, especially by close personal contact. In non-endemic areas, HDV infection is confined to persons frequently exposed to blood and blood products, primarily injected drug users and hemophiliacs who are infected with HBV. HDV infection can be introduced into a non-endemic population through IV drug users or by migration of persons from endemic to non-endemic areas. Introduction of HDV into non-endemic areas where HBV infection is common may lead to explosive outbreaks of severe hepatitis with high mortality. Treatment: patients with HDV infection can be treated with interferon alpha. Treatment of HBV should be continued as described earlier. Prevention: vaccination for HBV can also prevent HDV infection. General prophylactic measures are essentially same as that for HBV. Now coming on to hepatitis E. Hepatitis E virus HEV causes an enterically transmitted hepatitis primarily occurring in young adults, which occur as epidemics in developing countries. Morphology: although HEV resembles calciviruses, taxonomically it is distinct from them, hence has been assigned to a unique genus Hepivirus under the family Hepiviridae. HEV is small, 30 to 32 nanometer size, non-enveloped with icosahedral symmetry. It contains positive sense ssRNA and a specific antigen HEV antigen. Genotypes: HEV has single serotype. However, 5 genotypes exist in nature which differ up to 25% in their RNA sequence. Only 4 genotypes have been detected in humans. Genotypes 1 and 2 appear to be more virulent. Genotype 3 and 4 are more attenuated and account for subclinical infections. Clinical manifestations: incubation period is about 14 to 60 days, average 40 days. Most of the patients present as self-limiting acute hepatitis lasting for several weeks, followed by complete recovery. Fulminant hepatitis may occur rarely in 1 to 2% of the cases, except for pregnant women who are particularly at higher risk for 20% for developing fulminant hepatitis. There is no chronic infection or carrier state. Epidemiology: hepatitis E virus is a zoonotic pathogen affecting various animals such as monkeys, cats, pigs, or dogs. Animal transmission. It is fecally orally transmitted via sewage contamination of drinking water or food. Epidemics of HIV infections have been reported primarily from Asia, Africa, Central America. HIV is the most common cause of acute hepatitis in this zone. WHO estimates that hepatitis E caused approximately 44,000 deaths in 2015, accounting for 3.3% of the mortality due to viral hepatitis. Other parts of the world, temperate climate, HEV is uncommon and usually occurs in travelers coming from endemic zone. China reported more than 1 lakh cases of jaundice during an outbreak in 1986 to 1988. In India, HEV infection accounts for maximum 30 to 60% cases of sporadic acute hepatitis and endemic and epidemic hepatitis. The first major epidemic of HEV was reported from New Delhi in 1995, where 30,000 people were affected due to sewage contamination of the city's drinking water supply following a flood that occurred in Yamuna River. Though it resembles to HAV, the striking features that differentiate HEV from that of HAV are: secondary attack rate, transmission from infected person to their close contacts is rare, 1 to 2% in HEV compared to 10 to 20% in HAV. Age: young adults 20 to 40 years age are commonly affected in HEV infection compared to children in HAV infection. Now comes the lab diagnosis. HEV RNA by reverse transcriptase PCR and HEV virions by electron microscopy can be detected in stool and serum even before the onset of clinical illness. Serum antibody detection by ELISA. IgM and anti-HEV appears in the serum simultaneously with the increased levels of liver enzymes indicates acute infection. IgG anti-HEV replaces IgM in 2 to 4 weeks once the symptoms resolve and persists for years indicates the recovery or past infection. Treatment: there is no specific antiviral drug available. Prevention. General measures for prevention and containment of infection are the same as described for HAV. China has produced and licensed the first HEV vaccine called HEV-239 using combination HEV proteins. However, it is not yet available globally. Now, the last of hepatitis, which is hepatitis G. Hepatitis G virus HGV, also referred to as GB virus C, was discovered in 1995. It is related to hepatitis C virus, belongs to a family Flaviviridae under the genus Pigivirus. HGV is transmitted by contaminated blood or blood products or via sexual contact. Hepatitis G virus is wrongly named because it is not hepatotrophic and does not cause hepatitis. Instead, it replicates in the bone marrow and spleen. HGV is associated with acute and chronic liver disease but has not been clearly implicated as an etiologic agent for hepatitis. It has been classified into 6 genotypes, each has its own geographical distribution. HGV co-infection is observed in 6% of chronic HBV and in 10% of chronic HCV infections. HIV co-infection. HGV commonly co-infects people infected with HIV, prevalence 35%, but surprisingly, this dual infection is protective against HIV and patients survive longer. Now coming to the last topic of the chapter, which is yellow fever. Introduction. Yellow fever is an acute febrile illness. Severe cases are characterized by liver dysfunction which leads to jaundice, hence the name yellow fever, renal dysfunction and hemorrhage with high mortality. Taxonomy. Yellow fever virus is an arbovirus, belongs to family Flaviviridae. It is an enveloped virus containing ssRNA. Geographical distribution. Yellow fever is endemic in West Africa and Central South America. It is not found in the rest of the world including India. Typing. At least 7 genotypes of yellow fever virus have been identified based on genomic sequence, 5 in Africa and 2 in South America. However, antigenically it is homogeneous, only one serotype is known to exist. Transmission. Vector: human get the infection by the bite of Aedes aegypti or tiger mosquito. Transmission cycle. The two major cycles of transmission have been recognized: jungle cycle and urban cycle. Jungle cycle occurs between monkeys and forest mosquitoes. Urban cycle occurs between humans and urban mosquitoes, the Aedes aegypti. India. Yellow fever has not invaded India yet. However, India has all the potential of developing yellow fever in future. Because of the vector, Aedes aegypti is widely distributed here and India has a tropical climatic conditions similar to Africa. Various reasons have been hypothesized to explain the absence of yellow fever in India. Measures in airport. Government of India has laid down strict guidelines for vigilance and quarantine of the travelers in international airports. Unprotected, that is unvaccinated travelers coming from endemic zone to India will be kept in quarantine for longest incubation period, that is 6 days. Berthoud index or the Aedes aegypti index should be less than 1 surrounding 400 meters of an airport. Berthoud index, number of containers showing the breeding of Aedes aegypti larvae upon number of houses surveyed into 1000. Clinical manifestations. Incubation period is about 3 to 6 days. Febrile illness occurs in early stage of the disease and characterized by presence of fever, chills, headache, dizziness, myalgia, and backache, followed by nausea, vomiting, and relative bradycardia. Patience is viremic and in this stage and may be a source of infection for mosquitoes. Severe cases are characterized by hemorrhagic manifestation, platelet dysfunction, features of liver involvement, hepatitis, mid-zonal necrosis, and the presence of councilman bodies. Intranuclear inclusions may be seen inside hepatocytes called Torres bodies. Appearance of jaundice. Renal dysfunction. Encephalitis occurs very rarely. Mortality rate is high, more than 20%, especially among children and elderly. Lab diagnosis. Serology IgM ELISA can be done after 3 days of onset of symptoms. It gives false positive result in other flavivirus infections such as dengue, West Nile and Zika, and also in people who are recently vaccinated with 30 days. Hence, the positive result should be confirmed with a more specific test, that is plaque reduction or neutralization test. Molecular method. RT-PCR detecting specific viral NS5 region in the blood is more confirmatory than serology. It should be performed within 10 days of onset of symptoms, beyond which RNA becomes undetectable in blood. Epidemiology. It is estimated that about 2 lakh cases of yellow fever with 30,000 deaths occur annually worldwide, and majority of outbreaks occur in Africa. Epidemics usually occur in humid and semi-humid savanna area adjoining a rainforest. Infection to case ratio ranges from 20:1 in non-outbreak season to 2:1 during epidemic. All age groups are susceptible. Treatment. Yellow fever treatment is only by symptomatic care. Preventive measures include vaccination and mosquito control. Now comes in an important topic, yellow fever 17D vaccine. It is a live attenuated vaccine which is prepared by in allantoic cavity of chick embryo. Hence it is contraindicated in people having allergy to egg. There is no risk of encephalitis unlike the previously used mouse brain derived inactivated Dakar vaccine which was found to be encephalitogennic. In India, it is prepared in Central Research Institute CRI Kasauli. Strict cold chain has to be maintained during the transport of with a temperature range of -30 to +5 degrees Celsius. It is available in lyophilized form and has to be reconstituted before use. Reconstitution is usually done with dilutants such as physiological saline. Once reconstituted, it should be used within half an hour. Dosage single dose given subcutaneously. Vaccine is effective within 7 days of administration. The efficacy lies for up to 35 years. Validity of yellow fever vaccine certificate. Certificate is issued after 10 days of vaccination and renewed. That is reimmunization every 10 years. This is the recommendation followed for international travel. Cholera and yellow fever vaccine interact with each other, hence should not be given together. 3-week gap should be maintained. Contraindications of yellow fever vaccine include children less than 9 months, less than 6 months during epidemic, pregnancy except during outbreak, HIV infected people, people with allergy to egg. So this completes our chapter. Now let's come on to the expected questions. Uh, Write an essay on a 40-year-old male presented with a history of loss of appetite, malaise, and jaundice of 2 months duration. On examination, there was icterus, hepatomegaly, and tenderness in the right hypochondriac region. He gave a history of blood transfusion in the past. On laboratory examination, he was found to be positive for HBs antigen. So clearly, it is a case of hepatitis B, which is the most probable etiological diagnosis. Discuss in detail about the various lab infections and how can you prevent. This all we can write. Okay, now the short notes on yellow fever vaccine, lab diagnosis of hepatitis C virus we can write. Now coming on to MCQs, perinatal hepatitis B transmission is maximum during delivery. So option D. Okay, which hepatitis virus is associated with highest mortality in pregnancy? It is hepatitis E. Hepatitis virus that spreads by fecal-oral route is hepatitis A, and which is known as the Australia antigen. It is the HBs antigen. Okay, so this completes our chapter. Okay, like, share, subscribe. Thanks for watching.